Challenges of graft dislocation in autologous retinal transplantation. This patient underwent vitrectomy with gas due to a rhegmatogenous retinal detachment associated with macular hole, but he developed a recurrent retinal detachment. The retina was repositioned, silicone oil was implanted, but the postoperative visual acuity was hand motion with a persistent macular hole. The patient had macular changes since childhood associated with a choroidal rupture after an ocular trauma in this eye. Autofluorescence imaging evidenced an inferior displacement of the retina following the surgeries. An OCT revealed a persistent macular hole greater than 1,000 micrometer with irregular edges. A new surgical procedure was indicated involving the removal of silicone oil and autologous retinal transplant. Endodiathermy was then used to mark the positions of the graft area. A small retinal detachment was induced using a 38-gauge cannula, and with the help of curved scissors, the graft was cut to about 90%, leaving a small pedicle. The perfluorocarbon was then filled up to the area of the transplant, and the pedicle was cut. With the aid of a grasper, the graft was dragged to cover the macular hole. Endolaser was performed around the donor area, and the fluid air exchange was carefully performed. It is important to perform the FACS very slowly, using passive aspiration, trying to ensure that no residual fluid remains, to prevent the graft from moving out of place. Despite this caution, note that the graft moves from position when the surgeon begins the silicone oil implantation. The surgeon was able to reposition the graft adequately and finalized the surgery. 2 months after surgery, it is possible to see the well-positioned tissue on the OCT exam, and visual acuity improved to 2400. Postoperative microperimetry did not show significant improvement compared to the initial exam. Graft displacement during autologous retinal transplantation surgery presents significant challenges. To ensure proper graft positioning, strategies include thoroughly drying fluid during FACS. Other approach would be performing viscodissection and placing the graft in the subretinal space instead of leaving it above retina.